Hello, my name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement of MAVEN Project. Thank you all for joining us today and our friends at St. Joseph Candler Health Systems in Savannah, Georgia, for hosting today's session. Today's session is Pre-operative Cardiovascular Evaluation with Dr. Robert Lohr. Dr. Lohr was born and raised in Columbus, Nebraska, and he received his BA and MD degrees from Northwestern University in Chicago and completed his residency in internal medicine in Minneapolis, Minnesota. He entered practice and served as chair of the Department of Medicine, and then he accepted a position on the staff at Mayo Clinic. And at Mayo, he served as section head for the regional practice, and he became very involved with the Mayo Clinic Health System as medical director for its 800 physicians in practice surrounding Mayo Rochester. And then he continued to have an active clinical practice and resident supervision in both the inpatient and outpatient settings. And when he retired, he continued to work in a supplemental capacity in the Division of Hospital Internal Medicine. And he staffed the Mayo Pre-operative Evaluation Clinic and the Internal Medicine Consult Service, which focused on perioperative medicine. And so we're very lucky to have somebody as experienced as Dr. Lohr here with us today. So Dr. Lohr, I'm going to go ahead and turn it over to you and you can proceed.
Thank you, Jill, and thank you for the opportunity to talk with you this afternoon a little bit. This is a topic I know you deal with on a regular basis, and hopefully by the end of our time, you'll have a little more clarity about how to proceed and greater confidence as you approach these patients. Not advancing. There we go. So I have no financial disclosures to make. And as Jill has described, this is available for 1 hour of CME credit through MAVEN. Our objectives today are to understand the basics of a complete pre-op evaluation, although we're going to focus almost the entire time on the cardiovascular aspects, which often makes up a good portion, if not all, of the evaluation. We want you to know when to order testing and when it's not needed, and to become familiar with and apply some accepted cardiac risk evaluation tools. There are several out there, and we're going to go over a couple of them in some detail. And finally, to become familiar with and apply current ACC, AHA, American College of Cardiology, American Heart Association guidelines for cardiac evaluation before non-cardiac surgery. So you've heard more about me than you probably want to know, but I won't reiterate what Jill said. But I want to point out that I am not a cardiologist. And so if there are any cardiologists in the audience, please feel free to give us your impressions or speak up at any time. I'm a general internist, most of my career at the Mayo Clinic. And as Jill said, I have staffed an inpatient consultation service almost exclusively for a number of years actually, which focuses on perioperative medicine and the preoperative clinic. Very busy clinic. We would see 40 to 60 patients a day. We have over 100 operating rooms, and it's a robust surgical practice. They are full every day of the week. And I've had the opportunity to present perioperative topics both regionally and nationally. So why do we do pre-op exams in the first place? The purpose of the evaluation, even though that is almost always the request, please clear this patient for surgery, is not to give medical clearance. Rather, it's to perform an evaluation of the patient's current medical status, to make recommendations concerning that evaluation, management and risk of cardiac and other medical problems over the entire perioperative period, and to provide a risk profile for everyone involved in the patient's care. So the patient, the surgeon, and the anesthesia team. Now, the reason I say it's not a good idea to end your note with this patient is clear for the surgery is that if something goes wrong, which it can, despite all of our best efforts, you're a little bit liable for that. You cleared the patient and they didn't do well. So it's much better to say, I've evaluated the patient and they should be able to proceed with the planned procedure with the following recommendations, and then you can list the recommendations that you have. Now, when you're doing a pre-op exam evaluation, you need to think about all of these areas. And as I said, we're going to focus on the cardiac aspect today. There may be pulmonary risks, and actually pulmonary complications are the most common that we see. Many patients are diabetic, and that has to be managed. You're going to be responsible for managing them before the surgery and the day of, at least until they get to the hospital. So you have to help out with their medications. Many patients are anticoagulated for a variety of reasons. And so there should be recommendations about, do they need to have the anticoagulation stopped? If so, when to consider restarting, although that's generally up to the surgeon when they're comfortable that no significant bleeding will occur post-operatively. And if the patient's on warfarin, and I realize there's a smaller and smaller proportion of patients on warfarin these days because of the new agents, but if they are on warfarin, you have to consider whether or not they should be bridged. That meaning you would stop the warfarin, then cover them with low molecular weight heparin, then stop that, have the surgery, and then go on from there. We don't bridge very often anymore, but there are very high risk patients that sometimes require that. You need to make recommendations about the patient's medications. What should they take? What should they not take? Do any have to be adjusted dosage-wise? And you need to make sure that you include over-the-counter meds and supplements. And then there are other non-cardiac conditions that you need to take into consideration, mainly decompensated liver disease, renal disease, and thyroid disease. And thyroid refers mainly to hyperthyroidism. Liver disease can be very difficult to manage post-operatively, and I actually find them to be about the most complicated patients we have after an operation. If they start out with cirrhosis, they come in with a low blood pressure, it gets lower after the surgery. You give them fluid and it increases their ascites, but doesn't help their blood pressure. Their platelets and clotting factors don't work. They become encephalopathic with the pain medicines, and it just goes on. You always should ask about every patient, their anesthetic history, if they have one, bleeding and clotting history, including the family history, their alcohol consumption, and by that I mean how much and how often. To say that they drink socially is not an acceptable answer, and there are far too many people that go into alcohol withdrawal post-op. Their tobacco use, their steroid use to see if they need to be augmented, and then if they use other drugs, and chronic pain medication, including buprenorphine, which we'll talk about a little bit at the end. So let's start with the case. And I think this would be a typical patient that you might see. It's a 76-year-old male who's going to have an elective TKA, a total knee arthroplasty. He has a history of coronary artery disease that's been treated medically, so he has no stents and he has not had any other revascularization. He is not able to perform 4 METs, and we will define what that is, but basically it's walking up a hill or a flight or 2 of stairs of physical activity because of his knee, not because he's having angina or shortness of breath. He does, however, do water aerobics without symptoms, which is reassuring. The reason for the 4 METs, and we'll talk about this in more detail, is that patients who can do 4 METs, generally from a cardiac standpoint, do very well and don't require a great deal more evaluation. He takes metoprolol, 50 milligrams twice a day, a baby aspirin, atorvastatin, and lisinopril. Exam is pretty unremarkable, nothing that would really get your attention. And so you advise the following. Number 1, a ECG, a chest x-ray, and electrolytes. Number 2, a dobutamine stress echo. And it needs to be a dobutamine echo because he can't walk enough to exercise to do a regular stress test, and then have a cardiology consultation to follow that. Number 3 is a cardiogram, electrolytes, continuing his metoprolol, his statin, and his aspirin. Note that you're not recommending continuing the lisinopril. Number 4 is coronary angiography pre-op. And number 5 is the cardiogram, electrolytes, continuing the medicines, and do a DSE to facilitate additional recommendations. Now, I know we don't have any audience participation, but hopefully you can think about this a little bit. We're not going to spend a lot of time letting you do that, however. The best answer is actually number 3. So just let's go through why the others are not great answers. In number 1's case, you should make recommendations to continue the medication. So that's not adequate. Also, the patient doesn't need a chest x-ray. Many times you have chest x-rays ordered on a routine basis just because of the surgery, and that really is not needed. Now, if he had a pulmonary history, or if he had physical findings of something going on in the lung, then you should do one, but not on a routine basis. Similarly, he should have an ECG because he has a history of heart problems. But if you have one that's actually 6 months or so current, even up to a year in some cases, as long as the patient is clinically stable, you don't need to repeat it. Now, you don't need the dobutamine stress echo or the cardiology consultation, because even though he has the history of heart problems, he is able to exercise without symptoms. At least we're convinced that he is. So you don't need those. You don't need coronary angiography. And similarly, number 5 is redundant. You don't need all these other tests. So he needs a cardiogram if he doesn't have a current one. He needs electrolytes because he's been on lisinopril. And the metoprolol, statin, and aspirin should be continued in the perioperative period. Well, we're going to find out how we made those decisions. And I'm going to walk you through over the next several slides the ACC AHA guideline, which is actually 10 years old now, but it's the most current one, to walk you through how we came to those conclusions. So the first step, and this really wouldn't necessarily apply to you very often in the clinic, but it could, is the surgery an emergency? If it is, you don't do anything. You send them to the surgeon in the operating room, and they have to have the surgery. If it is not an emergency, then you do need to proceed with some additional things. So let's define urgency and emergency and risks. An emergency operation is one that you may have loss of life or limb if the patient is not in the OR in under 6 hours. So this would be a patient with a ruptured aortic aneurysm, maybe a patient who has a ruptured viscus that is percolated to sepsis, and they're going to die of that. Those are the sorts of things that you don't want to obviously wait for. Urgent procedures are life and limb threatened, if not in the OR, between 6 and 24 hours. And I think the best example of this would be a hip fracture. And the reason is that there's very good evidence and experience, for that matter, that delaying hip surgery, hip fracture surgery, whether it's going to be pinned or replaced, doesn't matter, but delaying it over 24 to 36 hours markedly increases complications, and many of them are lethal, particularly pulmonary emboli, patients go into heart failure. Most of these patients are elderly to begin with, so you don't want to delay that operation very long, but they don't have to go immediately to the OR. Time-sensitive procedures, you could delay 1 to 6 weeks without negatively affecting the outcome. And I think a good example of this would be a new diagnosis of a malignancy. You don't have to operate immediately, but you don't want to wait forever either. Elective procedures can be delayed a year, more than a year. Now, what about risk? The definition of cardiac risk, risk of major adverse cardiac events, which is death or MI, and it's abbreviated MACE. It's at low risk if the risk is less than 1%. If it is 1% or greater, it's considered elevated risk. And we'll talk about how we define the percentage. So step 2 is, and I call these showstoppers. These are active cardiac conditions that should immediately get your attention and actually result in a phone call to the surgeon saying, this patient has unstable angina, we'll say, And we can't proceed to the OR for this elective procedure until that's fully addressed. The surgeon's going to very likely say, when will that be? And your answer should be, I don't know. We'll proceed as promptly as we can, and we'll let you know as quickly as we can, but you don't want to lock yourself into a time frame that you can't fulfill. So most of these are quite obvious: unstable coronary syndromes, unstable angina, new angina, or an MI within 30 days. Now I have an asterisk there, and we'll talk about that in just a second. Decompensated heart failure or worsening or new heart failure, significant arrhythmias, high-grade AV block, Mobitz 2, symptomatic ventricular arrhythmias, SVT with a rate over 100, and symptomatic bradycardia. The most common things you'll encounter here would be the SVT with the rapid rate, AFib or another SVT. Those you want to control as well. And lastly, severe valvular disease, which most often is aortic stenosis. It can be mitral stenosis, but we don't see much mitral stenosis in the developing world because it's a result of rheumatic heart disease, which is a result of a strep infection. And in the developed world, we give people penicillin and we see very little, if any, rheumatic heart disease. That said, if you happen to be in a developing country, you may see a lot of mitral stenosis. And indeed, I spent some time in Haiti a number of years ago, and we saw a lot of patients with mitral stenosis. The aortic stenosis, though, is quite common, and you will see it. It's important to be able to determine on the basis of your exam and history if it is suggestive of severe aortic stenosis, because every patient you see won't come with an echo, before you see them. The echo criteria for severity is a gradient across the valve of over 40 millimeters, or a valve area of less than 1 centimeter. The physical findings of severity of aortic stenosis have to do with the characters of the murmur and also their carotid pulse. So this is a systolic crescendo decrescendo murmur, and severe AS generally is a late peaking murmur, so it's almost into S2, and the carotid upstroke is both delayed and diminished. It's called tardus and parvus. So you listen, and then you listen as well as simultaneously feeling the carotid. And if the carotid upstroke, normally you feel it immediately after S1, but if it's delayed and it isn't very strong, that suggests severity, and then you should get an echo. Now I want to go back to the timing, the first bullet here, and that's because there was a very recent study. It was just published in November of last year from the UK. They have their National Health Service, and so they have this incredibly large database. They looked at outcomes 30 days post-op, as well as 60, 90, and a year post-op. The 30-day post-op mortality was the primary endpoint, and the others were secondary. Almost 900,000 patients with CV events out of 20 million, so it was a big, big study. Among the patients, though, with a previous event, the post-op mortality was increased until there was a plateau at nearly a year, 11 months, for the primary endpoint, and a little over a year for the secondary endpoints. So this suggests, this is one study, albeit very large, that if you do have someone who's had a recent event, it may be better to delay a little longer than the 30 days that the guidelines say. Now, it obviously depends on what the operation's for and what is going on with the patient, and there's an opportunity to do some shared decision making. As I mentioned, if you have severe valvular heart disease or suspect it, then you need to go ahead and get an echocardiogram. And if that corroborates it, the valve should be addressed before the elective surgery. So if you're seeing somebody for a TKA or anything, and they have severe aortic stenosis, which is usually the case, then they should be referred on to cardiology and possibly cardiac surgery, depending on what type of repair they want to do. Now, sometimes you don't have the luxury of time to work things up. Let's go back to the hip fracture patient, an elderly patient, severe aortic stenosis and a hip fracture. We're not going to get the valve repaired before we have to repair the hip. So in that case, it's a conversation with anesthesia, with the surgeon, and generally ICU monitoring after the surgery. So Step 3, there aren't any active conditions that we just talked about. And if the surgery is low risk, so the major adverse cardiac events is less than 1%, you're done. You can send the patient to the operating room. If it is not low risk, then the next step is to assess the patient's functional capacity. So let's talk about risk for a minute. Low risk procedures are pretty much anything endoscopic, dermatologic, cataract surgery. And I'll pause here because I know you're asked to see patients for pre-op evals for cataract surgery. We don't do them anymore. It's a 20-minute procedure under local anesthetic, and it really does not require much of any medical evaluation. The ophthalmologist and the anesthesiologist can do what's needed. Very, very infrequently do you need to do a pre-op eval. Breast surgery is considered low risk, ambulatory surgery, and dental procedures. Intermediate risk are the main things that you're going to be seeing patients for: intraperitoneal and intrathoracic surgery, CEAs, carotid endarterectomy, head and neck, orthopedic, urologic procedures. The high-risk procedures you may or may not see. These are mainly major vascular surgery, also pulmonary and liver transplant and pneumonectomy. And the reason you may not see these patients is that if they have this kind of problem, they're often followed by cardiology or pulmonary medicine or gastroenterology, and they're going to be doing the pre-op evaluation. So, functional capacity. We want the patient to be able to do 4 METs. So climb a flight of stairs, walk uphill for a block or 2. 10 METs would be strenuous activity: swimming, singles tennis, basketball. If you can do 4 METs, you should be able to let the patient proceed. And that's why our patient in the scenario at the beginning did not have to have further cardiac evaluation. We felt that his functional capacity was adequate, and so we didn't need to do any stress testing of any kind. If they cannot do 4 METs, then you do have to consider further evaluation. Now, you can ask patients how they walk and so forth, but it's not terribly objective. And there's a very nice tool called the Duke Activity Status Index, or DASI, developed quite a while ago, and it objectively calculates METs. It's been shown to be more accurate than unstructured questions, and a score of over 34 suggests a decreased risk of 30-day MACE, death, or MI. Now, these are the questions, and I'm not going to go through all these with you, and you'll get the slides in a day or so. But this should be pretty easy for a patient to answer, and you could almost have your clinical assistant or nurse go through this with the patient and get a number pretty quickly. But I would recommend using something like this because it is much more objective than just asking about their activities in general. So, if they have clinical risk factors, then their major adverse cardiac events are likely going to be greater than 1%. And the risk factors are heart disease, a history of heart disease. So this is ischemic or valvular or heart failure, history of compensated heart failure, history of stroke or TIA, diabetes, and renal insufficiency. These are the things that contribute to cardiac risk. The most common and the oldest used tool to assess risk is the RCRI, the Revised Cardiac Risk Assessment. It predicts major cardiac events: MI, pulmonary edema, pardon me, VFib, cardiac arrest, and heart block. And the way you get points for the RCRI is if it's a high-risk procedure, which they actually define as intraperitoneal or intrathoracic or suprainguinal vascular, so central vascular procedure. A history of ischemic heart disease, you get a point. A history of heart failure or stroke, each get a point. Diabetes treated with insulin. Now, this obviously was developed well before some of the newer medications. It's still used, and insulin is still used, of course, too, but I'm not sure that that criteria is as valid as it was when this was developed way back in 1999. And then a preoperative creatinine of greater than 2, which usually suggests that the GFR is under 30. So these are the things that each will get you a point. Each will get you 1 point. And this is how this works out. So if you get no points, the cardiac risk is 0.4%, 1.9%. So class 1 and class 2 is under 1% low risk, less than 1%. Anything over that is higher risk. Now, this is another widely used calculator. It's called the NSQIP calculator. It's from the American College of Surgeons. And I'm going to walk you through this because it really can give you a very broad and nice picture of what's going on with the patient. So we have to say that we're not a robot and that we've taken all the risks. You have to name the procedure. So if you put in a word, they will have a lot of things that'll come up. And we're going to choose a pretty complicated procedure, a resection, peritoneal malignancy, bilateral salpingo oophorectomy, omentectomy, dissection and debulking, and so forth. So a complex procedure. You also have to say that that's the only option. And then you have to fill in a fair amount of data. We'll say this is a 50-year-old female, that she's independent. It is not an emergency. They do want you to fill in the ASA class. That's American Society of Anesthesiology. This has been around for many, many decades, and the anesthesiologists use it on every case. But it's pretty simple to use. Class 1 is a healthy patient. 2, mild systemic disease, so hypertensive patient is well controlled, and asthmatic is well controlled, diabetic well controlled. Severe systemic disease, any of those not well controlled. Severe systemic disease, constant threat to life, someone with active angina, that sort of thing, and then more of a not expected to survive. So this would be the emergency surgery, the ruptured aneurysm, the patient's already got in shock, that sort of thing. There is a class 6, which is for organ harvesting. So we're going to say that our patient has severe systemic disease. She has not been on steroids. She does have ascites because of her malignancy. She has not been septic. She's not ventilator dependent. She does have disseminated cancer. We'll say she is diabetic and she's on insulin. And we'll say she has some hypertension, no heart failure, no dyspnea. We'll say that she is a smoker. And she has some COPD, and she's not dialyzing. She's not an acute renal failure, and we're going to put her at high risk from the standpoint of her height and her weight. Okay, so we put all that data in, and this is what you come up with. I'm not a robot. Okay, so you get a nice picture of a lot of variables here. These are the risks of serious complications. They have this patient's risk, the average risk, and the chance of outcome. So serious complications, any complication, pneumonia, cardiac problems, and so forth and so on, it goes on. But it gives you a very, very broad picture of how this patient may do. And it can be very helpful, particularly in a situation where the patient or the surgeon are not sure whether to proceed. This may help make that decision. And it also otherwise simply gives you kind of a roadmap of what you may need to be dealing with postoperatively. So it's a very useful tool to use. Okay. Another one, and this is the last one, is called the AUB HAS-2, American University of Beirut. HAS is HAS, H stands for the heart disease, symptomatic disease, here we go, history of heart disease and a history of symptomatic disease. A is age or anemia, and S is the surgery, emergency, or vascular. And each one of these give you 1 point as well. And here's how this comes out. I'm sorry, each letter gets 2 points, but each of the categories gets 1. So the risk of MI, CVA, or death within 30 days, 0.3, 1.6%. So already from a cardiac standpoint, they're at high risk, and it goes up from there. So this is just another tool. This is also widely used. Most people will use the RCRI and then maybe supplement it with the NSQIP calculator, but some people like this one as well. Okay, Moving on, our MACE is greater than 1, and we can't assess functional capacity. So we need to think about further testing. So if our patient in the scenario couldn't do water aerobics or was having some chest pain, we would need to think about some other testing. You need to do it if the results will impact the decision to proceed with the original procedure, or if the testing is abnormal, they would be a candidate for revascularization. If it's abnormal, would you go to angiography? It is not, however, recommended by anyone to do routine coronary revascularization for non-cardiac surgery, specifically to reduce cardiac risk. So there has to be some reason to do this for the patient aside from the surgery. Now, what tests do you do? We like dobutamine stress echoes. The patient doesn't have to be physically able to exercise. It gives you a threshold where you will begin to see wall motion abnormalities and ischemia, and it gives you a pulse threshold below which, if you can keep the pulse below that, the patient should do well. So it can be helpful for the management actually during the operation. The Canadian guidelines, and I'll just touch on this, are quite different. They do not recommend any stress testing. They, and it's for the reasons that I just said. You shouldn't be doing stress testing just to decrease cardiac risk. There has to be more than that. So they recommend for patients over 65 or 45 to 64, if there's a history of all the things that give you points, they include severe pulmonary hypertension, then the patient should have a BNP. And if it is greater than 92 or the proBNP greater than 300, then they still don't do a stress test. They just say we have to monitor this patient very carefully post-op, ECGs, troponins, and co-management with a medical specialist, usually a cardiologist in this case. So it's quite different than the American guidelines, but this is what is done in Canada, and this is from 2017, so not too many years ago. So what do? I think the best way to do this is to take the surgical question out of the equation and ask yourself if you would recommend further testing and possible revascularization if you were simply seeing the patient for a general exam and there was no surgery at all. So if the patient comes in and says, you know, I used to walk my dog a mile and now I go 2 blocks and I have to stop because I have this pressure and so forth, you would probably do some further testing. If that's what's going on with the patient pre-op, then you should go ahead and proceed. If it is not, then I think you can proceed to the OR. Now, a few words about medications. Beta blockers. Older trials, very old, suggested that they were very helpful, particularly atenolol. But then that was discredited. They were actually found to be, there was found to be some fraud in the research. The POISE trial was then done, and this was back in 2008. And it suggested that there was actually harm from using beta blockers pre-op, now pre and peri-op. But then it was criticized, I think justifiably, because they took beta blocker naive patients and gave them enormous doses of metoprolol, 200 milligrams pre-op and then 200 milligrams 6 hours post-op. And not surprisingly, they had a lot of hypotension, and with that, they had a lot of strokes. Not as many MIs, but they had strokes. There's also been some retrospective studies that suggest that beta blockers may not be the best thing to do. So what should we do? Well, the current consensus, and it is consensus, not necessarily fully evidence-based, is that if a patient's on a beta blocker, you should continue it. If the patient is not, and they come in and have 3 or more RCRI risk factors, so they have quite high risk, you might consider starting the beta blocker. If, however, the patient has some other long-term indication but no RCRI risk factors, then there is no value in starting the beta blocker pre-op. If you do start, and this is extremely important, you don't want to start them right before the surgery. You need to start it at least a few days, a week, a couple weeks even, but beforehand, and then see the patient back and make sure they're not too bradycardic, they're not in heart failure, they're not wheezing, any of the major complications that can occur. So if you do start one, do not start the day of surgery. What about hypertension? Well, the bar is not very high here. If the pressure is less than 180 over 110, you should be able to proceed. Anesthesia is much happier with high blood pressure than low. You should instruct the patient in general to take their antihypertensives the day of surgery, with the exception of ACEs and ARBs. Pardon me. And the reason is that there are some studies that suggest that an ACE or an ARB can result in a pretty significant drop in systolic blood pressure with induction of anesthesia, about 30 millimeters. So the way I deal with this kind of a situation is that if the patient's blood pressure is really well controlled on their ACE or ARB or whatever, and whatever else they're taking, 110, 120, I generally hold it. If it's not that well controlled, 150, 160, I think you can go ahead and give them. You do need to make sure that the medication that you're holding for blood pressure is started post-operatively promptly. Otherwise, you'll get a call about the patient's high blood pressure. Statins can certainly be continued. There's some evidence that starting them in patients who have vascular disease is good. Most of those patients are already on, but it's not going to be harmful to start a statin. Alpha-2 agonists are not recommended for anything in terms of preoperative risk management. Now, antiplatelet drugs, many patients are on aspirin and other drugs. And this is the 2014 ACC/AHA guidelines, which I'm not going to go through because they revised them 2 years later in 2016. So we'll go through that. So these are patients treated with percutaneous intervention, so a stent, undergoing elective non-cardiac surgery. So if they've had a bare metal stent and they're treated with dual active platelet therapy, 2 drugs, 30 days, up to 30 days, you can't operate. So if it's less than 30 days since the procedure, you should not operate. If it's over 30 days, you can proceed. Now, as you know, we don't use many bare metal stents anymore, but there are situations where one is put in, or more than one, particularly if an operation needs to be done and the patient needs to be revascularized beforehand. You don't have to wait as long if it's a bare metal stent, understanding that the stents don't work as well. If a drug-eluting stent is placed, 3 months, nothing. 3 to 6 months, you can proceed, or you can consider it. And over 6 months, you should be able to do things safely. Now, the question then arises if it is safe to do it, either with a bare metal or drug-eluting stent. Should they continue both drugs? Now, most surgeons will not operate on 2 antiplatelet drugs. Most surgeons will operate most of the time on a baby aspirin. So if you have to stop the clopidogrel or ticagrelor or whatever else they're taking, you should be able to continue the aspirin. The one exception or 2 exceptions to that, and it is kind of surgeon dependent, are craniotomies and spine surgery, because the bleeding complications of those are quite catastrophic, but it's something that you need to discuss with the surgeon. What about post-operative troponins and things? Now, the Canadian guidelines differ on this, but in general, in the US guidelines, you should get troponins and ECG if there are symptoms that suggest there's a problem. But post-op screening in the absence of symptoms is of uncertain value. Now, again, the Canadians don't agree with that. The problem here is that the symptoms may be quite atypical. The patients are getting opioids for pain management, and their symptom may be nausea and vomiting. So you have to have a pretty low threshold. How about COVID? And I realize this isn't the easiest thing to see, but and you don't have to pay any attention to the stuff below, but up in the table, I'll try and walk you through this. So on the left side, we have time from the COVID-19 diagnosis. Asymptomatic, mild, or moderate illness with COVID, if it's less than 7 weeks since the diagnosis and they have low risk of MACE, delay the surgery. Obviously, if they have elevated risk, you delay the surgery. If it is over 7 weeks, and they are now asymptomatic, you can proceed. You can, if they have elevated risk, but you have to be more cautious and be thinking about it a little bit more. Now, if they have severe disease with COVID, less than 7 weeks since the diagnosis, you delay in all situations. If it's over 7 weeks and symptoms are persisting, you still delay in all cardiac situations. If it's over 7 weeks and the symptoms have resolved and they're low risk, you can proceed. If it's high risk, again, you have to be pretty thoughtful about it and make sure that you need to have the surgery in the first place. So the thing to remember here is 7 weeks. But there was a fairly recent study about a year ago now, just about, again from the UK, and they looked at the timing of surgery post-COVID between 2018 and 2022. They didn't have a huge percentage of procedures that were done under 7 weeks, but they did have some, and again, these are large studies, so there's thousands of patients. After vaccines were widely available, the mortality was 1.1% if the surgery was within 2 weeks of the COVID diagnosis, and 0.3% if within 4 weeks. Now, these are patients that were asymptomatic. They did not have ongoing symptoms and didn't have real severe COVID. But this does suggest that in the asymptomatic patients, and surgery is urgent, that you may not have to wait the full 7 weeks. Okay. OSA should be screened for every patient that gets a pre-op exam, or every patient should be screened. You can use whatever tool you want. Stop bang is probably the most common one. And the reason is that untreated and unrecognized OSA really has some severe morbidity and mortality not so much in the OR, but after the OR. Now, if you have a patient that you think really has severe OSA, they have all the physical criteria, they're snoring, they're falling asleep mid-sentence as you take their history, you probably don't have time to do a full sleep workup before the surgery. You might, and if you do, then you should do that. But the least you should do would be to make recommendations about continuous oximetry, particularly for the days when the patient's getting opioids for pain management, and consider ICU monitoring and moving a procedure from outpatient to an inpatient setting so that they can be monitored further. Finally, medications. I just want to run through this. This is, again, a fairly busy slide. We talked about ACEs and ARBs. Other blood pressure medicines basically can be given. The one other exception would be a diuretic. And the reason for that is the IV fluid and the fluid shifts that go on. It's pretty hard to predict what's going to be going on. And so usually diuretics are held the day of surgery, and maybe the ACEs and ARBs. How about for diabetes? PO meds in general should be held. Most often this is metformin. If the patient's on an older sulfonylurea, that should be held. Ultra long-acting insulins can be given at the usual dose. Now, the caveat here is that if the patient's first morning sugar, when they check it at home, is on the low side, 90 or 100, I would probably cut down maybe by a quarter or even up to 50% the dose of the Lantus. If it's 120, 30, 50, you can give the entire dose. And as you know, the ultra long acting insulins don't peak, they just reach a plateau and go along. Intermediate insulins, you should cut by 50% the day of surgery. So if somebody is on 10 of NPH twice a day, the morning of surgery, they should just get 5 units. The new drugs, the sodium glucose inhibitors, should be held 3 to 4 days pre-op. Now, the reason for that is, as you may know, these drugs can cause a normoglycemic ketoacidosis. And that can happen perioperatively because the patient's not eating, they're getting IV fluid, and they're getting these drugs. And checking ketones is not a routine thing to do. So these should be held several days before the surgery so they're out of the system. The glucagon receptor agonist should be held the day of surgery, or if it's an injectable form, the week of surgery. And the reason for this is that, as you all know, I'm sure, these drugs are quite effective at weight loss or for weight loss. And the mechanism is delayed gastric emptying, which is a recipe for aspiration if you're having an operation and general anesthetic and you're in the OR. So these also should be held for the surgery. We talked about beta blockers. Other cardiac meds can be continued. Certainly anticonvulsants should be continued. You don't want the patient to have a seizure when they wake up. Pain medicines can be continued. And I'll say a word about buprenorphine. You can continue it. It used to be that we thought you had to taper off and so forth, but now with greater use of it, I think it can be continued. Unless the patient is taking a lot of it. So if they're taking more than 16 milligrams a day, then you may want to taper them down to that level and then let them continue at that. The reason for this is that that you have to use just enormous doses of other opioids to control the pain if they're on a high dose of buprenorphine. Parkinson medicine should be continued. Patients NPO, they don't eat in the hospital, time to get out of bed and they can't move. So you want to continue those as consistently as you can. MAO inhibitors, we used to say you couldn't give, but you can. And inhalers in general should be continued. If someone is using a PRN inhaler, PRN albuterol, for example, I usually have them take it even if their breathing's fine the morning of surgery, because there can be a risk, there is a risk of some bronchoconstriction with induction of anesthesia. And I believe that is the last slide. So I know we have some time for questions. I'm going to unshare myself here. And if we have questions, I'd be happy to take them on any perioperative topic. I also want to make a plug here too. There is a perioperative medicine, there are consults available, e-consults or video consults. So if you have complicated patients or questions, go ahead and put a consult in. There's only two of us that staff it. I do, and Jim Bird, who is an anesthesiologist in the San Francisco area. But please, utilize that service. Otherwise, thank you so much for your time, and let's see if there are questions. Jill?
Great. Dr. Lohr, thank you so much for that great presentation. And thank you also for promoting that additional specialty available on our community portal for people to submit consults to. So Dr. Miller has a question. Since many COVID infections are mild and patients are often not seeking care or home testing, there are likely many undiagnosed infections. When considering pre-op risk, should we be asking patients about recent upper respiratory infection, flu-like illness, if they have had a recent undiagnosed URI or flu-like illness and the surgery is elective? Should we consider recommending delaying surgery in case the undiagnosed URI was indeed COVID? That's a great question.
Yeah, it is. I think, when COVID first started, everybody coming into the OR had to be tested or was tested before the surgery, even if they were asymptomatic. And the reason for that mainly was because if they had COVID, they were exposing the entire operating room team to COVID and taking that team out of circulation for, several days to a week until the time period went off. The time period that you had to stay out of work was done. So as you're correct, many people have asymptomatic or minimally symptomatic disease. I think it's still, if they've had a history of a URI, it's not unreasonable to do a COVID test and see if it's positive. Again, for the same reason that you don't want to expose the people in the hospital to COVID. If you can't do that, you could say, let's just wait the 7 weeks, or if they're really asymptomatic and it was minor, according to that one study, which was a big study, you may not have to wait that long. But I think it probably makes sense if someone comes in with URI symptoms and has not tested for COVID, that is best maybe to test them and see where they are with it.
Great. Thank you so much. And if anyone has any questions, feel free to put them in the Q&A icon on your Zoom toolbar. Or if you want to raise your hand, I'm happy to have you ask a question verbally. And Dr. Lohr, just there are some comments. One says, I didn't realize there were so many risk calculators. I like the Canadian model with eliminating stress testing altogether. And another did not know that there were MAVEN consults for perioperative consults for complex patients. Good to know.
Now, let me comment on the Canadian thing. And this is really only from a potential medical legal standpoint. If you're not in Canada, and I think you're in Georgia, and you follow the Canadian guidelines and things don't go well, you might get yourself into some trouble. So I like them too. But that said, I think I would wait until the US guidelines are altered. And I'm guessing that they may get altered fairly soon because, as I said, the ones we're using are 10 years old and they get reviewed periodically, but there hasn't been anything that convinced the cardiology folks to change much up to this point anyway.
Great. And then just since you were touting the different consultation rooms for MAVEN Project, I just wanted to draw the providers who have accounts to their attention. This is a list of all of our MAVEN Project specialties and wanted to call out also we have a complex cases room. So if you have a patient where there's multiple organ systems and you're kind of stuck with what to do or how to approach it, you can submit there. Those volunteers actually have up to a week to respond since they're giving a more thorough response usually. And then I just want to show you where the perioperative medicine is, and you can see Dr. Lohr right here. So you can submit consults to him as well. And then also just wanted to highlight that mentoring is also available for MAVEN Project for those of you who haven't participated. And this is one-on-one mentoring. It can be clinical mentoring. It could be leadership mentoring, and we would match you with one of our stellar MAVEN Project volunteers, and they meet with you. It could be every other week for an hour. And just it's a confidential relationship, and it's kind of working with a combination of a preceptor and a coach. And they're there just to help you. So you can go onto the MAVEN Project site, click mentoring, and you can learn more and submit a very brief inquiry form that tells us a little bit about you. And we try to accommodate it to your schedule. So I'm going to come back here, and there's an additional question. Do you find that surgeons who request clearance push back when you provide risk analysis, but no formal clearance? That's a great question.
Yeah, it is. No, I don't find that to be an issue. They almost always the request for you is to provide clearance. The idea is just to not use the word clearance in your assessment, and they're not going to push back about that at all. I also, the surgeons don't want things to go badly in the OR or afterwards, so they're, I think, uniformly happy to have some help and some recommendations. I won't gloss over this and say everything goes smoothly 100% of the time. The biggest issues that come up in my experience have been the patients who are very high risk for thromboembolic phenomenon and restarting anticoagulation post-op. Many surgeons are reluctant to do that until the patient goes home. And sometimes you compromise, you'll put them on a prophylactic regimen, which is better than nothing, I guess, but there's really no evidence that it's truly going to prevent thromboembolic stuff in terms of stroke anyway. So you do have to compromise and be reasonable. And the surgeon is responsible for the care of the patient postoperatively. They're the captain of the ship in the hospital. So, but I don't think you'll get pushback. The time that I have gotten pushback is when they have pre-ordered all kinds of things that are not needed. I want a chest x-ray, I want a cardiology consult, I want this, that, and the other thing. And, you contact them if you know the surgeon well, it can be a pretty nice discussion, and often things will go fine and you won't have to do things. But if you don't know the surgeon at all, usually they're gonna get done. I have a separate talk on on just routine pre-op testing. And the bottom line of that is that there should be no routine pre-op testing. It all should be based on the history and the physical and the situation for the patient.
Wonderful. That's great. Dr. Lohr, thank you so much again for presenting, teaching us, guiding us, supporting us. And thank you so much to all the MAVEN Project Clinic partners. You guys are amazing. And thank you so much for taking such good care of your patients and always looking to learn more and to share. So I hope everybody has a happy Valentine's Day tomorrow and a good rest of your week and stay healthy. We really appreciate all of you.
Thank you. Thank you for your time today, too.